Hello, everyone, and welcome to the Toronto General and Western Hospital Foundation virtual Q&A. We hope you are staying safe and well and taking care of each other during the COVID-19 pandemic. I'm Christian Cote, host of the UHN podcast, Behind the Breakthrough. We're glad you could join us and grateful that you could be with us today, especially to our family of supporters who've been so generous throughout these challenging times. A big thank you to you from the foundation and all of UHN. This episode, we're talking about what else, the second wave, the latest on testing, and a strategy for fighting the virus called the hammer and the dance. As always, we'll be taking your questions on Slido, and to help us understand the latest on what's going on, we're pleased once again to have the expertise of Dr. Alon Vaisman, UHN infection control physician. Welcome to the live stream, Dr. Vaisman.
Thank you for having me.
So we've entered the second wave of the COVID-19 pandemic. What do you attribute the dramatic rise of cases this time around?
So the explanation for the cases could simply be just the natural progression of what happens when you move into phase 3. So if you look at Ontario and Toronto specifically, move into phase 3 in late July, early August. So this is approximately 6 to 8 weeks after that. So this could just be the natural progression of that. In other words, the rules that were set in place would inevitably lead to this. The other explanation, which most people are more commonly supporting, is that people are not as adherent as they used to be to the rules regarding masking, regarding distancing, and meeting in small places or in crowded places. So one reason we think that is that there's a lot more young people involved in the infections this time around, and the kinds of activities that they've been participating in are ones that predispose people to picking up the infection.
The Premier of Ontario recently actually said this will be worse than the first wave and more complex. What does that mean to you?
The difference between this wave and the first, it could be that there'll be more of an attempt to try to maintain normalcy when it comes to functions in the hospital and also keeping businesses open. So as a result, there's going to be more of a crunch of having patients who have COVID in terms of the numbers, but then also trying to maintain some economic stability and trying to maintain businesses. So that adds another layer of complexity. Whereas in March, there was a simple approach, which was to shut everything down, including, for example, surgeries in hospital. All non-essential workers in the province were shut down. Now, because of the economic effects, there's going to be more of a balancing act, and that could be quite complicated to manage.
Exactly. And there's been a lot of focus on the incidence of spread, especially at restaurants and bars. If someone is immune compromised or in the other high-risk categories for getting the virus, what's your recommendation about going to places like that?
Now that the number of cases in the community has risen quite dramatically over the last few weeks, I think more and more people who are immunocompromised or more vulnerable are going to be a little bit more hesitant to go to those places. Also, there's a lag in the number of cases that we know about in terms of testing and the symptoms that people develop. So it's probably even a little bit more than what we're actually seeing. So given that we know that some of these places have been sources of outbreaks, especially bars, then those individuals are probably going to be a little bit more hesitant, and I would say less likely to want to go to those places. We know that you can open those up in times where numbers are low. So if people have the a little bit of ability to keep away from those places now, in the long run, it'll be beneficial to be able to go to them later when numbers are down again.
In terms of the rise in numbers the last few weeks, do you have any sense when you parse the numbers, Dr. Vaisman, how much of this can be, or can any of this yet be attributed to return to school?
That's a great question. The return to school in the Toronto area was approximately the second or third week of September. So we would be seeing the effects of that approximately now, which is about 2 weeks after that time. But was interesting, so certainly the return to school led to transmissions, there's no doubt about that. But interestingly, if you look at the slope of the curve as it was rising in the first, second, and then third weeks of September, it was already starting to go up even prior to schools opening or just as schools were opening. So what we have now is a situation where two elements are kind of interacting. The community prevalence was rising due to a variety of reasons, including people not adhering to practices. And then secondly, the element of schools opening. And those two things are now kind of feeding each other. And we'll see what direction that goes in the next few weeks based on what restrictions are added on by the province.
So, in terms of schools and daycares, I see some Toronto schools have declared COVID-19 outbreaks. What's your guidance to families who are feeling reticent about continuing to send their kids to school?
It's a very hard call to make at this stage. I think there could very well be a situation where not only do schools close down individually, but also an entire school board shuts down, either in Toronto or elsewhere, because the number of outbreaks is excessive. There's too many going on, and there's too much transmission. But I think each of those parents have to make the decision on their own, because now that parents have experienced the first wave, depending on the age of your kid, it might have had a very significant effect on their social ability, their education. So whether or not a parent chooses to proceed now is really based on their specific circumstances. I know that some parents feel that they want to continue for as long as possible now, because the not having their kid in school will have such a dramatic effect on their child, while others, they just feel the risks are too high and they're looking for alternatives to educate their kids. So there's no one answer for everyone. I think the schools and everyone are trying to do their best to maintain safety, and that's all we can do in the meanwhile until the situation kind of declares itself. And looks like so far the cases are just continuing to rise.
And I don't mean to put you on the spot because I know these guidelines just came out today, but I'm wondering if you maybe could give parents a bit of a PC of the new guidelines for how you're supposed to conduct, I guess, the safety of your children if they start to get sniffles, cough, or even a fever. What's your sense of what the guidelines had to say today in terms of guidance for parents?
Yeah, the general idea behind what is recommended from public health is to get your child tested if they have any kinds of these symptoms. The challenge is, though, that COVID-19 will have very similar symptoms in young children as any other respiratory virus. So upper respiratory symptoms like cough or sneezing or sore throat. So it's very hard to distinguish based on symptoms alone whether your child has COVID or not. But because the cases are rising so dramatically in the community, the likelihood that your kid has COVID now has risen. Whereas before, a few weeks ago in early September, most likely it was just a common cold. Now there's more likelihood that you have COVID. So the public health recommendations are to your best abilities, and it is becoming more and more available to have young children tested. And of course, have them excluded from school and congregate settings in order to prevent the transmission when anyone is symptomatic.
Uh, and I have to bring this up. At the end of the month, we have Halloween, which is, so many kids look forward to it. How would you counsel parents on the idea of door-to-door trick-or-treating?
So first thing I would say is that assuming that there isn't a system-wide lockdown or massive curfew that's in place in October during Halloween, and if that's not in place, I would say overall trick-or-treating is not high-risk activity. I would call it low risk. Specifically going outside to do trick-or-treating, any kind of indoor party for Halloween is high risk, or doing trick-or-treating in like an apartment or condo building. Unfortunately, those are probably a little bit higher risk. But if referring to being outside, there's a lot of things you can do to try to minimize the risk. You can maintain distance when you're going door to door. You can maintain distance between yourself and other families for trick-or-treating. You can also wash your hands before eating anything. And you can also avoid certain foods that are not individually wrapped to avoid any kind of contaminated products. So overall, if certain conditions are met and care is taken, I think overall trick-or-treating can be low risk. It just depends on the specifics of your situation and your neighborhood.
And if I could, I know this is drilling down a bit finely, but kids and masks, there's tons of costume masks for Halloween, but would you still say, please wear either a cloth mask or one of those masks we get at the hospital?
Generally speaking, if you're outside, you don't need to wear a mask. However, if you're interacting in an environment where you can't reliably assure that you're not going to come in close contact with an individual, then you should wear a mask. But when we talk about masks, it's Halloween, like a typical Halloween mask for a costume probably doesn't provide much of coverage. Neither do things like bandanas. So, if you are going to wear a mask, you could either try to incorporate it into your costume, I suppose, like a surgical mask. But otherwise, something like a 100% cotton mask, that would be totally fine. It would protect you. But again, it depends on your scenario. If you're trick-or-treating in an apartment building, and again, with proper distancing and proper measures in place, then yes, you certainly wear a mask. However, if you're outside with a lot of space where you're not coming in contact with people, you don't necessarily have to wear a mask in that context.
Okay, well, thanks for that. Um, the source of transmission is it's so crucial to mitigating outbreak, fighting the virus. And yet I've read that a big issue in Ontario is that about half the confirmed cases have no known epilink. Can you tell us what that means and what the concern is there?
Yeah, so every time a case of COVID is documented by the public health authority, each regional authority will contact the individual and do a history. Where were you in the last 14 days? Who did you interact with? What did you do? And they try to establish where the virus could have come from. And the reason that's so essential is because it guides, first of all, it guides the tracing itself for that specific person, calling the contacts to make sure that they're isolating. But it also guides public health decisions. So if suppose 50% were actually accounted for, we'd have a better idea of what the next steps are. So if, say, a giant chunk of cases are coming from bars or coming from congregate settings, then we would know that's the targeted approach we should be taking. Take the flip side, if, say, a vast majority of cases are actually coming from parties or weddings or those kinds of activities, then the messaging would target those, and it wouldn't be much value in shutting down bars. But if you don't know, if about half either the results are delayed or you simply don't know, then you're kind of operating in the dark. You don't really know which measures are going to help and which are going to help right away. So that's the key part to try to understand. The alternative is just to shut everything down like we did in March, but I think the appetite for that is a little bit less now, and people are looking for more of a precision approach to hopefully avoid a lockdown this time.
Yeah, that's right. So on this notion though of tracing, the tracing protocol in the province, is it your sense maybe that it needs to be beefed up?
Yeah, if there are delays or if people are not able to identify where they picked up the virus, then we do need to have a better way to try to do that. Usually that means hiring more contact tracers. If there's delays, which there have been reported in the last few days in people being contacted by public health, then there needs to be more people available to do that. And of course, that's not easy to do, to hire lots of people and very quickly train them on how to do contact tracing. But this will help us in the long run. It'll help us be able to get on top of the virus as soon as possible.
Yeah.
The other side of that is having people be very honest. When a contact tracer calls you, you should be very honest about what you did. There's no need to feel necessarily shame or to be blamed, but at that stage, you've got the virus. You should just tell them exactly what you've been doing in the last 14 days, and that's going to help a lot. If we don't disclose what's happening, we won't be able to stop the virus.
It really is like a civic duty to protect us all.
I agree.
Accessibility to testing and the long lineups, they've certainly emerged in the last couple of weeks, 10 days as a friction point. What's your sense of what's going on here? What's at play?
So on one hand, you could look at the lineups as a good thing in the sense that people are aware they need to be tested and that there's a good public health campaign that's been going on for the last few months, that recognizing that if you have any symptoms, you should go get tested. On the flip side, of course, the more obvious downside here is that for whatever reason, the capacity is not there to provide testing for people. So although the lab capacity is quite large, the choke point seems to be the testing centers themselves. So as part of a mitigating strategy, the government has introduced testing to be done in pharmacies. And this was done in Alberta, for example, many months ago. So you have a wider variety of people who can do testing so that people aren't standing in line. Various testing centers, including our own at UHN, have moved to doing appointments. And they've also moved to restricting the indications for testing. And we may talk about this in the next few minutes, but by restriction, what we mean is trying to target only those who would really benefit from a test. I'm not talking about the heavy restrictions we had way back in January and February, where very narrow amounts of people would get tested, but a more sensible approach. Rather than saying anyone can get tested at any time, which has a lot of downsides to it, especially when there's a lot of symptomatic people, we should really be targeting the high-risk individuals, people with either high-risk exposures, and of course, people who are symptomatic.
Well, maybe we'll unpack that a little bit more because yes,
Sure.
the mantra in terms of the Ontario government has been, I think, for a long time, if not from the beginning, anyone can get tested, which some experts I've read, certainly epidemiologists say, that's good politics, not good science. And I've read where some people are getting tested simply for reassurance. What is your guidance as of today on the wisdom of getting tested now that we're in wave 2?
So if we had a system of a high or unlimited resources where testing was widely available, there was no lineups, there's no choke points, the assays for the test, then yeah, I would say everyone should get tested whenever they feel like it. In a situation where there is a pandemic and cases are either rising or there's uncertainty about it. However, because we don't have an unlimited amount of resources, because unfortunately we do have a limitation in the number of tests we can do in the testing centers, then the approach really should be for anyone who is symptomatic to take priority to be tested. If you don't have symptoms, the recommendation is always to isolate regardless. If you have symptoms that are consistent with COVID, you should be isolating. If you have no symptoms, there isn't an indication for you to be isolated. So if you've been, let's say, a high-risk exposure, let's say you've been in contact with somebody who has had COVID, but you yourself have no symptoms, regardless of what your test may say, you will be isolated for 14 days, period. If you develop symptoms in that 14 days, absolutely you need to get tested. If, however, you develop no symptoms in that 14 days, getting tested won't change the management. I understand that some people feel that testing in that period may make it a little bit more easy or palatable for people to understand the need for isolation. So if you swab positive, for example, it's more explicit. You see it on a piece of paper, you see that you're positive, you understand the need to isolate. But still, I think the education should be that regardless of what your test may show, if you have a high-risk exposure, you're getting isolated regardless.
Terrific. What's your read then on the emergence of new methods of coronavirus testing? There's saliva testing. There's another method called rapid point of care tests. Do you think they'll be in wide circulation soon? And more important, that might help the burden of testing in terms of at the testing centers?
So the saliva tests have been made available in some sites in Toronto and approved by the province as well to be made available. And really the advantage of doing, for example, a saliva test is that for very young people who can't tolerate a nasopharyngeal swab, it may be easier to do a saliva test for those people. Also, there's some individuals who have abnormal anatomy or who have nosebleeds, who recently had surgery on their nose, for example, who can't tolerate a nasopharyngeal swab. So saliva testing may be easier for those. But generally speaking, unfortunately, saliva testing, as far as we have it here in the province, the sensitivity isn't as good. So picking up the virus may not always be as good as the nasopharyngeal swab. So generally speaking, and also unfortunately, the turnaround time for saliva testing is no better and maybe even worse than the nasopharyngeal swab. So there's not much benefit in doing the saliva testing for the majority of people at this time. As for the point of care testing that you're referring to, there have been some kits that have become approved, widely used in America and some approved in Canada. The thing about those is that if you're going to use a point of care test, you need somebody who's trained at doing it. So if you're going to do it in a setting like a home or somewhere, you need to have, or a workplace, for example, you need to have somebody who's trained and able to do it, and also make sure that you're using a validated kit. Also needs to be purchased. So I would say that overall, still the standard should be the nasopharyngeal swab, and then for some maybe narrow indications to use those other methods of testing until those become more reliable and more accessible.
Terrific. I want to move into maybe what we might call some big picture questions with you on getting the case count back down and under control, which is going to be the big concern, at least over the next few weeks, if not longer. Then a reminder to everyone out there that we'll be getting to your questions coming in on Slido, and keep them coming. In terms of strategy during this second wave, I'm reminded of an excellent essay that was published very early in the pandemic called The Hammer and the Dance. Do you mind explaining the premise of this strategy and give us your sense of the effectiveness of the hammer and the dance?
Yeah, it was a concept put out earlier during the pandemic by some epidemiologists. And the basic idea is that if you picture the curve of the cases, as the cases begin to rise, you put in very strict measures to try to reduce case counts immediately. And as the cases fall, that's what we call the hammer, or the hammer portion of this kind of curve. So during this period, what you're trying to do is trying to cut down the virus counts as much as you can. So you're looking for better ways to treat people. You're recruiting people to help with various things in hospitals, contact tracing, public health. You're trying to build capacity in the hospitals, in the government, to make sure that you can handle the pandemic. And then you do a lot of analyses on the virus and the spread of the virus to try to understand what's going on. When the case counts drop to a minimal level, now you're into the phase that was termed the dance. What you're doing here is you're pulling back on a lot of the restrictions, but you're still doing a lot in terms of educating the public and still banning like the large gatherings that are going to lead to explosive case counts. And here you're using what you learned in the hammer phase to try to maintain a low level of cases, what you understand about the transmission of the virus. And now those cost benefit interventions that you learned about during the hammer, now you're applying them in the dance. And so you have an availability to tighten up or to loosen where possible, but you have the expectation that you may very well need to go back into the hammer in the dance. So there's this kind of ebb and flow to the process. The hammer, where you're doing a lot of things very quickly and at a high level to shut down the cases, then the dance, which is more the relaxed phase, where you're still vigilant, but you're keeping things at a low level with the virus.
So, this week we saw the release of new modeling in terms of projections for the next few weeks, how that might affect ICUs across the province in terms of hospital capacity. Is it time, from your perspective, from what you're seeing and the projections, for the hammer to be brought down again?
Yeah, it's a very, the easy thing to say is to lock everything down. And of course, that has great advantages to it. You can shut down entire society and you'll cut down virus very, very quickly. The question is to what extent we have to do the elements of the lockdown in order to achieve those results. And that's always a very challenging question to answer. The flip side is the economic cost it has to it. Of course, the cases are rising dramatically. So we do need to see more restrictions. I would say moving back to phase 2 or some of the elements of phase 2 at this time, that would be a reasonable step to take at the moment. I'm not a public health expert, so these are something important to ask the public health experts and see what they say in terms of their research, in terms of their opinions. But this would seem to me at least a reasonable step, that a few more additional restrictions are required at this time, given that the case counts have risen. And I should also say that not all numbers are created equal. 500 cases in September is not the same thing as 500 cases in April. One simple example of that is just the fact that the higher proportion of young people in September compared to then. And one of the proofs of this is that we're seeing lower ICU admissions for the moment compared to when we were in April. So it's true that the case counts are rising. For now, the mortality isn't as high as it was, but we can't wait until it gets that high before we move into higher restrictions. So the name of the game is to avoid a complete lockdown. And then the tricky part is finding ways to selectively restrict elements of society to avoid a complete shutdown.
You want to give us any forecasts or predictions based on what you see happening or unfolding over the next several weeks?
Yeah, this past week has been the most dramatic in terms of the case counts. We saw on Monday, of course, the single season record that we've had, or all-time record actually, of more than 700. That's kind of an artifact of the testing and those backlog of testing on a Monday. But it is suggestive that there's no sign that cases are dropping over the last 3-4 days. So it looks like if we don't do much in terms of restrictions, we're just going to continue to rise over the next few weeks, and that we're headed, depending on what's done, we're headed for a pretty sharp rise in the middle of October, maybe the end of October. Hopefully we can, if things are done quickly and some of those extra restrictions are added on, hopefully by the end of October, we'll see a peak. Again, you have to wait 2 or 3 weeks before you start to see any kind of effect from what you're doing. So there is always a lag in the expectations.
So we should also mention, be very mindful of physical distancing, wearing masks, washing your hands, etc., as Thanksgiving approaches. So be very careful.
Absolutely, yeah. And that goes back to the very first question you asked, is why are we having cases? That's why we're having cases. It's just a ton of people who are unfortunately going into settings where they are very close, making contact. Maybe they have mild symptoms, maybe they have no symptoms, and they're transmitting the virus to each other. We're talking about social gatherings, patios, weddings, all sorts of various functions. This is what got us into it, and stopping those activities is what's going to get us out of it.
Thanks so much. Okay, it's time for you and your questions that have been coming in on Slido. A ton of them today, and we appreciate your engagements. It's fantastic. Let's get right to them. From Ian Binney, Dr. Vaisman, what is the UHN doing to push Ontario and federal health authorities to move much faster on the development, approval, and manufacture in Canada of rapid antigen tests, paper strips? PCR technology is plainly inadequate for mass screening for infectious individuals.
That's a good question. Certainly, there is advantages to using these rapid antigen tests. As we discussed, you can potentially have point of care testing. Again, it requires a certain amount of cost to be invested and also the expertise of people to be able to do it quickly. At UHN, we currently have a huge capacity to do nasopharyngeal swabs. I don't know specifically on what the current status is of antigen testing here is. I'm sure it's being looked into, but I just don't know whether that's going to come here in the very short term. This kind of thing is more looked into in the public health level, like the Public Health Ontario lab, for example. So here at UHN, the primary mode of testing still will remain nasopharyngeal swabs with using PCR technology.
Next from Avis, based on news reports, hair loss, lung, kidney, and heart problems are side effects of having been ill with COVID-19. Are these to be considered official long-term side effects? And if so, how is it none of the three levels of government's public health offices has been informing the general public?
Yeah, that's a great question. So now that we're 7 months into the pandemic here in Ontario, but even longer across the world, there is very clearly evidence that people have long-term consequences associated with COVID. The science is still being developed in this area. So it's not, the proportion of people developing this and what are the specific risk factors for developing this. For example, who's going to develop long-term cardiac manifestations or who's going to develop chronic fatigue symptoms associated with COVID. That part is still not clear. So I think public health officials, if they have been hesitant in discussing this, they haven't, it's only because the science isn't yet concrete or formalized yet. The other thing is that this is less of a, the message that public health keeps going with is the acute effects of COVID, which in and of itself should be convincing for people to perform the things they need to do to prevent transmission. Whereas the long-term consequences, of course, they are debilitating for some individuals, but they may be less stressed by public health offices only because they want people to focus on the sudden and acute manifestations of COVID, which can be deadly.
Next from Anonymous, and this must be to do with the new testing that's going on at pharmacies. Are the COVID tests at the pharmacies as reliable as the ones in hospital?
Yeah, so as long as they're performed by somebody who's trained, then ultimately the COVID test itself, the swab itself, will go to one of the labs that we use in the hospital. So Public Health Ontario, for example, the lab here located just in downtown Toronto, they actually perform testing for a variety of locations in the GTA and across the province. The hospital, the Mount Sinai Microlab, which UHN uses, also accepts swabs from a variety of people in the city, a variety of places. And then depending on the pharmacy, you may go to one of the standard labs as well. So effectively, as long as a swab is taken by a trained individual, then there isn't any concern about the reliability of a test there.
Next question from Tom. Why are governments not telling us much about where the new infections are occurring? Is there anything we can do to push for greater transparency?
Yeah, that's a great question. It goes back to what we discussed earlier about the contact tracing. So this 50% of not knowing, or whatever the value may be from day to day, it's absolutely crucial that we find out about it. And this goes back to the ability to contact trace as many people as possible. And I suspect that it will be determined, but there is some delay in the reporting of that. And what can you do to push for that is, the usual kind of advocacy things with public health officials or politicians, to notify them, whatever it may be, social media, writing letters to make them aware that this is an important part of getting on top of the pandemic.
Next question from Lisette. My question concerns the COVID-19 death rate in this country. To date, the death rate of Canada due to COVID-19 is at 6%. That is twice the world rate at 3%, and even USA at 3%. Should we be addressing our treatment methods versus other successful countries?
That's a great question. There isn't any reason to suspect that Canada is suboptimal in treating its patients. There's many centers of excellence across Canada in terms of intensive care units everywhere across the country. The likely reason why the mortality rate is higher in Canada than it is in other nations is that the proportion of people who died as a result of COVID from long-term care facilities, that is to say elderly people, is higher in Canada than it is in most of the developed world. So the proportion at one point, for example, in May and June was close to 80%. This, of course, has fluctuated. But at the point being that if the higher proportion of people who are affected by COVID in your country are elderly people, then you will have a high mortality rate. And also the mortality rate depends on the values of elderly people in terms of wanting to be treated. Some people in some countries will choose not to be treated or not to go to hospital. Some people will. And then in Canada, there's also the issues we've had with LTCs managing the outbreaks, making sure that there's, for example, infection control support in those areas. So the high mortality rate, I don't think it's likely due to suboptimal treatment, but more likely to the types of patients who are getting COVID in Canada.
Okay. From Anonymous, why does the virus affect some people so much harder than others? Can you explain what it actually does to the body?
Yeah, it's a great question that we're slowly learning about. One potential explanation for why some people have severe disease versus mild is the inoculum, this amount of virus you get, that large volumes of virus inhaled or infecting one person can lead to a more severe disease versus a small amount of virus. And then beyond that, there's factors about an individual which predict if you're going to be more sick that are similar to other infectious diseases, such as being elderly, such as having immune compromise, such as having other comorbidities like diabetes, obesity, high blood pressure. But then there's going to be a certain aspect of a patient's clinical status that we simply don't know why. So for example, one 30-year-old may have severe disease and one 30-year-old may not, and we don't have a good explanation as to why. It's something in that person, some variable, some genetic factor perhaps that predisposes them. What happens when the virus enters the body is that it enters through your mucosal membranes and into the respiratory tract. And the primary damage is in the lungs itself, where there is either the virus has a toxic effect on the lung, coupled with the immune response of the body that causes a severe inflammatory response in the lungs, which is the primary reason why most people will die as a result of COVID. This massive immune response, to varying degrees, can contribute to people's morbidity. The virus can leave the lungs, and it's been found in various parts of the body, including in the brain or in the gut, for example. But the primary reason why people die from the virus and people have complications is related to the pulmonary, the lung manifestations of COVID, the direct effect of the virus with the immune system response.
Next question. Is it safe to take a mask off and put it on again as you go from one store to another? If so, what are best practices?
So generally speaking, you don't need to take your mask off in between stores. The reason you would take a mask off at all would be, well, first of all, to discard it. And the reason you would discard a mask is if it's damaged, if it's contaminated, if it's soiled in any way, if it's moist, then you would just get rid of it and wear a new one. If you're taking it off simply because you're going to, to walk in the park and then you're going back into another store, then in that case, you need to make sure your mask is situated or placed somewhere that is clean and dry and non-contaminated. So some people might use a bag that's dry and making sure not to touch the part that's going to be facing the inside of the mouth or the face. But if you have a good supply of masks and you choose to just take it off, and you might as well just discard it and wear a new one to avoid contaminating yourself, especially if you don't have easy access to sanitizer. So anytime you're touching your face, including taking off or putting on a mask, you should use hand sanitizer to avoid contaminating yourself.
And another mask question from Linda. Are disposable masks have more protection than cloth masks?
So generally speaking, disposable masks are more reliable because when you buy a disposable mask, what we call procedure or surgical masks, you have a box that says the specifications on it, so you can actually see that it's been hopefully approved for use as a mask. So there's just simply more reliability, whereas cloth masks tend to be, could be homemade, could be sold by some unreliable producer. Sometimes you just simply don't know. But some masks that are made at home are not necessarily poor in quality. If you had 100% cotton mask, for example, or if you had a mask with additional filters on it, it could be just as good in terms of bacterial filtration. It just simply, you may not know depending on where you bought the cloth mask from or how you made the cloth mask. So those can be good. But if you have any doubt about it, disposable masks are generally, there's no doubt that they work well.
From Lorraine, in the spring, I heard that COVID droplets lasted 25 seconds in the air. Currently, I'm hearing 3 minutes. What is the current thinking on this? I'm assuming that this just applies to indoors. Is that correct?
So there isn't a set time that we know that the COVID droplets will suspend in the air. It could be the matter of seconds or it could be a matter of minutes. And the reason I say that is that it all depends on the ventilation in the room. And I know we've talked previously about this whole debate between small aerosols and droplets. The point is, regardless of what you're sneezing, what droplets you're generating, the ventilation is important in the room. So if you have a very large room that's well circulated, well ventilated, the droplets are less likely to maintain in the air versus a room with stagnant air. It's more likely to remain there. Certainly outside, this doesn't have any relevance, and it's just as quick as gravity can pull it down, which is probably in a matter of seconds to maybe a minute or several minutes, but it's likely not to be very long. So there isn't a specific set time, but in any event, regardless, if you keep distance, you're less likely to acquire the virus. So that's why, although 6 feet isn't a hard and fast rule and doesn't actually have that much evidence to it, it's an approximation of how far we should keep people apart in order to avoid transmission.
All right. If one believes one has been exposed to COVID-19 but has no symptoms and decide to take a test, how long after the exposure should one take the test? I.e., what is the incubation period? Also, if we are tested after arriving from overseas and we are tested negative, do we still have to quarantine? I think I know the answer to that question.
Right. So this goes back exactly to what you were asking earlier, is that if you have a high risk exposure, you ought to be isolating for 14 days. You may choose to go get a test, but it doesn't change the fact you need to isolate. In fact, one reason why you might not get tested is, one, you might have a false sense of security when your test swab is negative. Secondly, you have to go out into the public to get tested, which means you're potentially exposing other people. So if you're already at home and you've been called, you have a high risk exposure, you start isolating then and there. You start isolating from your family and friends as well. You don't have any more contacts. You don't need to be tested. And if you've gone, the reason is also because even if you test negative on day 5, say, that doesn't rule out disease on day 6 or 7. So the recommendation is to isolate for a full incubation period, 14 days, or on average, the peak would be 14 days. As for traveling, once you return to Canada after you've traveled, you will still be required to quarantine for the 14-day period, unless you have some exceptional circumstance, like you need urgent medical care, for example. Outside of that, you're required to isolate, and you don't need to be tested in that setting either for the same reasons.
Yep. From David Grant, I've read through more than one reputable source that catching COVID through surfaces is negligible versus droplets from speech and breathing. It's not suggesting that we shouldn't use hand sanitizer, but more that catching COVID via surfaces is a very minor player. You still agree with that in terms of the surfaces being a minor conductor of the virus?
Yeah, initially when we're learning about the virus back in the winter, there was a lot of thought that fomites or inanimate objects play an important role in transmission. But now that several studies have been done, in environmental studies where they've swabbed surfaces and looked at the viability of the virus, it seems like there is accumulating evidence that surfaces are not as important. It's hard to say whether we should describe this as negligible, but the important thing is that we should be focusing more on distance and mask usage more than we should be about cleaning surfaces. That's not to say we shouldn't be cleaning surfaces. We actually should be, and we must be. But if you wanted to sort of rank them in terms of importance, likely it's the droplet inhalation from face-to-face contact, which is the most likely source of transmission. But in fact, it doesn't actually change what we do. We should absolutely be cleaning surfaces when we're in contact with people, like common areas in public spaces.
Right. From Gail, how do we weigh the risk benefit in long-term care homes about continuing to allow family members to enter homes as a caregiver? Risk of spreading the virus versus social isolation if no family allowed in the home. That's a tough one.
Yeah, there's no easy answer to that. But when the case counts are high enough, then the life the preserving life in that long-term care facility will always take precedent than the presence of a caregiver. So, that's unfortunately the reality when the case counts are extremely high. And the extreme version of that is an outbreak. If you have an outbreak in a long-term care facility, allowing caregivers at that stage is a very dangerous thing to do, because the prevalence of the disease is already so high in the facility that you don't want to introduce anymore. You do everything you absolutely can to try to reduce transmission, and cutting off caregivers is one of the most, or not just caregivers, but anyone who's out from outside. Cutting them out from entering the facility is one of the most important things you could do immediately. So in outbreak settings, there's no doubt that we try to reduce people from outside entering as fast as possible. But it's when you have a facility that's not on outbreak, how do you balance that risk? And we saw the decision was made in March that because the cases were so rapidly rising across the board, we just cut off all visitors, not just to long-term care facilities, but also hospitals. And of course, it had a negative consequence on patients, because the social isolation, no doubt, is very important for patients with cognitive impairment. So it's impossible to be able to make that call about when decisions are made. We all are looking now for when is that trigger? When is that trigger where the community cases are so high that these individuals will not be allowed back in LTC? Nobody has the right answer, but it's going to be a consensus that people come together on.
Yeah, very tough. From Jane, pharmacies are now setting up to test for asymptomatic persons. Is this safe for all customers and staff?
So certainly it's safe as long as you set up a location in the pharmacy where the healthcare worker is wearing the appropriate PPE. It's segregated from the rest of the pharmacy, where in a separate room, door closed. There's no doubt about safety. But the question is about necessity. As we discussed earlier, is there any necessity to test asymptomatic person? For the vast majority, there isn't. The cases where we do think asymptomatic testing is very helpful is, generally speaking, in hospital settings or in outbreak settings, in order to try to identify where the outbreak came from, and in order to try to reduce the transmission very quickly. So broad testing of asymptomatic people in an outbreak, for example, or just before declaration of an outbreak, is very helpful. But your average individual in the community, just testing asymptomatic, again, has limited value in general.
Next question. I'm concerned about flu shots. I'm over 90. And where will this take place?
Yeah, so absolutely, for a 90-year-old, getting the flu shot is recommended. And the places where this could take place is a variety of places, including pharmacies, including the family physician's office or primary caregivers, nurse practitioners as well, and then also hospital settings. So the place where you might choose to get your flu shot is the one where you're least likely to come in contact with lots of people, or the one where you can easily access it. You can go in and out and get the flu shot without any problem. So for some people, that might be a pharmacy, some that might be their primary care physician, some of them might be a walk-in clinic even. So any one of these places would be safe as long as you just reduce your exposure to other people and plan it out very carefully.
Now, just a programming note for everyone. We were scheduled to wrap in just a couple of minutes, but I'm wondering if everyone, including you, Dr. Vaisman, are you able to stay on? Because we have quite a volume of questions. I know we won't be able to get to all of them, but we would like to include some more if you're able to give us a little bit more time.
Sure, no problem.
Fantastic. Next question. If possibly exposed to someone infected by COVID-19, how soon might one give a positive result to the standard test?
So if you're going to test somebody every single day, which again is not necessary, the average incubation period is approximately 5 or 5.5 days. And we know that your viral load will start to rise approximately 24 to 48 hours prior to that. So on average, you may have a positive swab 3 days after exposure or 3 to 4 days after exposure. But there will be some people who have a positive test even before that, maybe on the low end, 1 to 2 days after exposure. But the majority of people would be positive on day 3, 4, or 5. And then on the long end, it might be day 14, but that is very rare. Most people, more than 90%, will have had a disease by day 10 or day 11, approximately.
Next question. Are there any air cleaning machines that one can use indoors to safeguard a room from COVID-19? I understand that the infralight machines are iffy. Are there any other kinds of machines that are useful? Where can they be purchased?
So in non-hospital settings, having these portable filters put into your room or it's not really necessary. There would have to be some kind of very unique situation where it's a room that you have to be in, that the air is very stagnant, where multiple people are congregated in. But again, you should try to avoid those places altogether. But really, there's not much purpose to having a air filter, like a portable air filter in your room, like buying one and putting it in. Again, the principles here are trying to maintain ventilation. Although HEPA filters or portable filters can clean the air, one downside of them is that they do create turbulent flow in the air of the room. So if you have viral particles settled on surfaces, there's a theoretical risk that you're disturbing them and putting them up in the air and you could inhale them. So that's not to say they don't have a value. In certain settings, for example, in healthcare, we do use them, but in general, they're not necessary in non-healthcare settings. As for the infralight, I'm assuming they mean maybe UV machines.
Yeah.
To clean the surfaces. Again, we don't use them here at UHN or most hospital settings, and they're not really recommended for non-healthcare settings either. There isn't much added value. If you wanted to decontaminate surfaces, you could do that using, wiping them down, and then also using disinfectants as well.
Will outdoor settings offer the same protection in colder temperatures as it did in warm weather?
Yeah, that's an excellent question that we somewhat know, somewhat we don't know about this. So when Australia and the Southern Hemisphere went through their winter just now over our summer, they did see lower volumes of other respiratory viral infections as a result of all the COVID restrictions. And in some parts of, say, Australia, there was certainly low case counts of COVID, but in other parts, it exploded of course, in Melbourne and that state. So we don't know exactly, but the other thing is that in the Southern Hemisphere tends to be warmer in general during the winter months. In Australia, it's not nearly as cold as it is on average in Canadian cities. So we don't know, we can't necessarily extrapolate to Canada. We do know that being outside in general offer the advantage of better circulation, not being in close contact with one another in the outside setting. But the absence of the UV light, which provides some degree of killing of the virus, is generally less present in the wintertime. So it's hard to know whether that will be offset by the fact that you're outside. But in any event, one of the reasons we have flu season in general is that people are congregating more in the winter and closer contacts. So it's going to be that's going to be the more concerning aspect of the exposure rather than being in outdoor settings.
And here's the $64 question. When are we hoping that a vaccine for all will be available?
When are we hoping? We're all hoping for right now.
Yeah.
The recent news from the Moderna vaccine, which was one of the leaders, is that it won't be as was promised by the politicians in the US. It's not going to be available before the US election, for example, as was. So that's likely going to be delayed a little bit further. I think most people would practically say that sometime in 2021 we should expect something, but Dr. Fauci, the leader in America who is leading the COVID response, even he has changed his predictions on when the COVID vaccine should be available, when you can expect it to be also effectively rolled out. So early 2021 would be the most optimistic of all the guesses, but that is very optimistic.
For some reason I thought it was going to be November 3rd, but anyway. Next question. Are social bubbles or social circles to a max of 10 people still in effect? How does this work now that kids are back in school and daycare, taking buses, etc.? What happens when we need to shift bubbles? What are the required steps to safely move from one social circle to another?
Yeah, the simple answer to how does this work now that kids are back in school is that it doesn't work. So a great quote from Dr. Davila, the head doctor in Toronto from a few days ago, is that you can forget about the idea of bubbles. They don't exist anymore. At this stage, given that schools are open, but also that people are not adhering to practices, the simple advice that she gave, which is very sensible, is that if you don't live in a house, then you don't enter that house. So it's as simple as that now, is that you can't reliably say that I have 10 people. I'm not even sure anyone ever was able to maintain that, because often there'd be one or two people who are connected to one or two or other people. So it was good in theory to try to maintain as a construct to try to reduce your transmission by keeping a low number of people in your bubble. But now that idea is completely out the window because of kids and because of a variety of other things. So don't start counting people in your bubble anymore. And you can't really move between bubbles either. You just have to reduce you just have to reduce your group. That's really all you can do.
Yeah. Yeah. I think we're back to flatten the curve.
Yeah.
Christine, where can one get COVID test and a certificate for traveling purposes required by a visiting country?
Yeah, that's a good question. The opportunities to get tested are, of course, the hospitals, including ERs, but that would not be a good use of an ER to go get tested simply because you need to travel. There are also the COVID assessment centers, which can be tested. Because the rules around testing have been a little bit more restricted over the last week or two, I'm not certain whether they will provide a test for people who are simply wanting to go travel. So it may be a little bit more challenging. Maybe it may be helpful to connect with either a travel clinic or connect with your primary care physician to give you advice on where the best place to get tested would be in your local area.
Now, I'm not sure if this next question is something you can field, but we'll put it out there. How are medically necessary biopsies prioritized in COVID-19 times?
Yeah, that's a great question. So what we do here in UHN, what the physicians and the interprofessional team have looked at is, for every specialty, they've looked at what kind of procedures are life-saving and essential, and then worked around how they're going to book people for those things. With surgeries in general, unfortunately, there's a backlog since the first pandemic in getting elective surgeries done. With biopsies, I guess it depends on the indication for the biopsy. But if there is any indication that it needs to be done within 2 weeks, then those are done. Like there's no doubt about that. People still understand, the physicians and all the teams here still understand the necessity of performing procedures, even in the time of COVID. So, for example, if you have a patient who's admitted to hospital who has a concerning lump somewhere in their body and they need a biopsy, it will be performed as an inpatient, or by any kind of indication for biopsies. It all depends on a case-by-case basis, but people can be rest assured that care will be provided here when it's necessary.
Very good. From Debbie, when will the high-dose flu shot be available?
So we're thinking it's going to be in the next approximately week or two. Typically, it's available around that time of the year, this time of October. So people should be contacting their local clinic, as I mentioned earlier, to figure out when and where they can go, either their primary care physicians or their nurse practitioners who are providing them care. It should be approximately 1 to 2 weeks, give or take, based on previous years, based on what they're saying.
It's a great question coming up here. What are your thoughts about attending a routine dental appointment at this time in general, and attending the routine dental appointment at this time when pregnant?
Yeah, that's a great question. It's hard to evaluate the risk, but I would say that it is far lower risk for the person receiving dental care than for the person who's doing the procedure, because you, as the person who's getting the dental care, there's a lot of precautions that are taken on their side to try to reduce transmission, including screening healthcare workers, including wearing masks, including all sorts of infection control practices. Whereas the dentist who's providing care doesn't have as much assurance from the individual that they will be properly screened, for example. But as a patient, you have to just kind of evaluate yourself what the risk might be for you. If something is necessary because of there's an urgency to get some dental care, then you should just try to get it done as soon as possible, because the longer you delay, the more likely the dental clinics are going to be closed down. If it's something like routine cleaning that could wait a few months, then perhaps you should. Ultimately, the best person to ask this question would be the dentist or the dental hygienist who you're looking to get care from, and talk to them about what their clinic practices are and talk to them about what they're doing.
Next question from a sports enthusiast, obviously. How safe, dangerous are team sports during this second wave? The WHO recommends not wearing masks, but staying 1 meter apart. But in a lot of sports, that's not possible 100% of the time. Does that athlete should wear masks when playing?
Yeah, it's going to be challenging because if you follow any of these guidelines about keeping distance is you're not going to be able to do with, depending on the sport you're playing, of course. So soon enough, I think a lot of these things are going to be shut down entirely, these kinds of sports where you cannot maintain distance. Wherever possible, you should wear masks. It just may not be practical depending on the sport you're playing. If you're exerting yourself, it may be difficult when you're taking deep breaths and huffing and puffing to wear a mask. It may become comfortable, but wherever possible, people should try to wear masks.
It'll be certainly tough at beer league hockey.
Yeah, exactly. So again, it goes back to your people's personal assessment of risk. But overall, I think these are the kinds of activities we should try to be cutting down now in the hopes that we can avoid a lockdown altogether.
I think we'll make this the last question today. And thank you to everyone out there for all your questions. We're sorry we couldn't get to all of them. From Michael, with the second wave here or coming hard, do you expect elective surgeries to be postponed once again?
Yeah, that's a great question. Most hospitals right now, what they're trying to do is maintain as much of their practice as possible for as long as they can. Whereas before there was an immediate shutdown, now there's going to be a little bit more delay in shutting down elective surgeries. And the reason is that the backlog of elective surgeries from the last few months is enormous, and they want to make sure they're providing care for as many people as possible. So if we are able to maintain low COVID inpatient volumes, and again, speaking to what we were talking about earlier, we don't have right now as many inpatients, for example, ICU patients or even ward patients as we did if you look at the same number of Ontario cases back in April, for example, suggesting that it's a different population that has the virus. But for now, that's the case, and we can maintain elective surgeries. But if it goes higher, we're not going to be able to do that. So that's the goal, try to maintain them for as long as possible. But if things continue to rise, and really the number you're looking at there is the inpatient admissions and the ICU admissions, if those numbers rise, that's when elective surgeries are going to be canceled again. Hopefully we don't enter to that, but given the way things are going, it wouldn't be surprising.
We've got to end it there. We've come to the end of our time. And to all of you out there in the audience, thank you so much for joining us. And of course, again, to Dr. Alon Vaisman, UHN infection control physician, thanks so much for taking the time out of your busy day to share your insights and expertise.
Thank you again for having me.
This live stream, as always, will be available on the Foundation YouTube page. For anyone interested in donating supplies or support items for our frontline workers, you can email COVID support, that's all one word, COVID support @uhn.ca, and someone at the Foundation will be glad to help you out. And finally, as always, we'd like to ask if you have the capacity for donor support. It's critical to the work we do at UHN, especially at this time, both in the front lines, as well as the hundreds of researchers behind the scenes working to find safe and effective treatments for this deadly virus. So if you're able to give, we ask you to consider making a donation. Visit www.tgwhf, that's tgwhf.ca/help now. Thanks for tuning in, everyone. Keep practicing physical distancing. Wash your hands, mask up, and stay safe.